Hi, I'm Brad Power, and this is the Cancer Patient Lab. And we're honored today to have with us Aruna Rajan, who's going to be helping us learn about minimum residual disease testing. She's a colleague of Sandra Valladares, who is our leader of the breast cancer community and an expert in diagnostics. And Sandra will introduce Aruna and moderate the session today.
Perfect. Thank you very much, Brad, and welcome everyone to today's presentation. I'm very happy to have Aruna presenting today about what is the status, market status for the adoption for minimal residual disease. So Aruna is the Chief Scientific Officer and co-founder for MA360i, and she has spent nearly 20 years helping healthcare and life sciences teams understand what patients and providers truly need. She founded Rajan, a small strategy firm to focus on thoughtful, patient-centered insights. Before starting her own firm, Aruna worked for Illumina and Life Sciences Consulting, where she helped translate complex market questions into clear, practical guidance. Her work has always been centered on making information easier to understand so that better decisions can be made. About Market Access 360 Insights, this is a startup that helps make sure important cancer tests have a fair chance of being covered by insurance, which means directly also implemented into clinical practice. Many promising diagnostic tests struggle to get reimbursed, not because they don't work, but because insurers need specific types of evidence before they can approve a coverage. And MA360i uses AI and data to figure out exactly what insurance companies look for, identify missing evidence, and guide test developers on how to strengthen their case. By helping companies build the right kind of clinical and economic evidence, MA360i gives this test a clearer and more predictable path toward insurance coverage and adoption into clinical practice. Thank you very much again, Aruna, for joining us today. This is a very exciting topic, given that MRD is obviously of interest for many of the cancer patients here and also survivors. And with that, I'm going to pass you the ball. Thank you very much.
Thanks, Sandra. I appreciate the introduction. Just a quick correction. So I'm the Chief Strategy Officer of Market Access 360 Insights, which is MA360i for short, and the co-founder of the company. So with that, I will move on to the next slide. So I do have a lot of slides, right? So I'm going to fly through some of them and then come back to it during the Q&A sessions if there are any questions or if there's any need to go deeper into some of those slides. So welcome everyone. Thank you for joining this session. It's meant to be like an interactive session, so do stop me if you have questions. We don't have to wait until the Q&A session. So goals of the webinar is to provide a clear understanding of what minimal residual disease testing is. So just a quick caveat. I'm focusing mostly on minimal residual disease testing for solid tumors. This is not a session about MRD. There's a term called MRD, which is measurable residual disease that's used for hematological malignancies like leukemias and lymphomas as well. That is quite well established, and different technologies are used for that. And they're part of guidelines, and a lot of those tests are reimbursed. What I will be covering here is the topic about minimal residual disease when it comes to solid tumors and how it works, why it matters for cancer treatment. And then we'll walk through some of the evidence and considerations today and some just practical guidelines. I have some mock-up cartoons that I've created just to give some guidance for patients on how to talk to your caregivers and providers. With that, I will quickly start. So my company, Market Access 360 Insights, MA360i for short, is a startup company. We help diagnostic labs get paid for their innovation. using AI-powered reimbursement intelligence. Our mission is simple: help diagnostic innovators get paid for their breakthroughs using AI-powered market access insights. So we're focused on connecting clinical evidence with real-world reimbursement realities. So that's enough about us. So let's talk about MRD. So what's the need behind this MRD test, right? Why do we need it? And what's the unmet need? So the unmet need is standard surveillance, using imaging and other protein-based biomarkers. They detect tumors only when they are large enough to see. So tiny clusters can, be left behind after surgery or treatment, and they grow silently. And so what MRD does is it identifies disease months before imaging does. So what is MRD? So MRD is a term that's used to describe small amounts of, cancer cells that are left behind after treatment. So detecting those molecular levels is what MRD is. And majority of the technologies that are out there today detect MRD using this term called liquid biopsy, which basically refers to some of these biomarkers that you see in the picture here. So cancer cells, this is a cancer, and they shed DNA into the bloodstream. And so what liquid biopsy does is it takes that, tumor sheds DNA into the bloodstream. It takes that DNA and then it analyzes that DNA for different types of mutations. There are also cancer cells that are in there. You can also analyze the cancer cells, but majority of the technology that's on the market today look at the tumor DNA that's shed into the bloodstream for different markers. So where is MRD being used today? So MRD is being explored across many solid tumors, including colorectal cancer, breast cancer, lung cancer, and muscle-invasive bladder cancer. There's growing research in other tumors like melanoma, kidney cancer, and pancreatic and prostate cancer. Its role is, expanding as the science and the evidence is developing more and more. So what MRD using liquid biopsy enables is it gives the provider an opportunity to intervene early before, a recurrent mass is detected on the scans. And then it also provides an opportunity for providers to then decide, or oncologists to then decide if they want to de-escalate or escalate, therapy. When therapy is de-escalated for patients who are not at high risk, then it prevents the patients from having to go through toxic therapies and face side effects. So the use case for MRD there's a lot of use cases for MRD. So there's a use case for, across adjuvant settings. So when we talk about adjuvant setting, it would be post-surgery. Sometimes after surgery is done for early stage cancers, there's a decision that's made by oncologists to see whether, further treatment like radiation or chemotherapy or any other treatment needs to be given post-surgery. So it can be used in that setting. It can be used in the surveillance setting where you would use this in parallel to imaging or to monitor recurrence. And then you'd also use it in the therapy response setting where you're looking at how the tumor is responding to therapy and looking at molecular progression for recurrence. I know it's a little bit of a complicated slide with a lot of explanation. Happy to bring it back if there's questions or if you want to see it a little bit more detailed manner. So in terms of MRD testing for solid tumors, companies are taking two different approaches. One is a tumor-informed approach, where post-surgery the tumor tissue is sent out and it's profiled, and using that profile of that tumor tissue, a liquid biopsy test is then customized for that patient based on that tumor to then figure out how to, monitor mutations based on their tumor tissue profile. And that's the tumor-informed MRD test, where it's like a bespoke, tailored approach based on what that tumor tissue blocks genomic profiles is. And then there's the tumor-naive approach, where companies like Guardant Health would basically then just straight out draw blood after surgery and then take the circulating tumor DNA and then profile it and look for, methylation and other markers out there to then, give information about the tumor and MRD. So why is MRD important in cancer care? It's important to basically guide to detect relapse, months before imaging and help personalize treatment intensity. It improves early detection while reducing unnecessary side effects for patients who show no molecular signs of disease. So it's a more sensitive detection than traditional monitoring. It supports more personalized treatment decisions and also helps avoid overtreatment, reduces toxicity, and basically enables timely action in high-risk patients, right? So if there's a high-risk patient and there's a high chance of recurrence, then it helps the oncologist and your team spur into action sooner than if you're just using imaging or other protein-based biomarkers that are part of standard of care today. It's applicable across a wide range of cancers, and it's a key component of precision medicine. Now I'll move on to I know I'm moving fast. Please feel free to ask questions if there's any. We just talked about what MRD is and what problem it's solving. So let's just quickly go through the evidence limit and limitations and adoption barriers associated with MRD testing. So today, MRD has shown that that it positively predicts recurrence across multiple cancers with high sensitivity and long lead times over imaging. But prognostic value is quite clear that it has high sensitivity, but evidence showing that MRD guided treatment actually results in improved survival is still ongoing. So that's why MRD testing for solid tumors is still not part of NCCN guidelines. And a lot of private payers, commercial payers have still not have still not started reimbursing MRD testing yet. So, what we preach at Market Access 360 Insights, MA360I, is no test will get paid if it's not covered. So, even strong technology needs strong evidence because, payers only cover tests that meet rigorous clinical and economic criteria. So without coverage, patient access remains limited, no matter how promising the science is. So payers only don't respond to marketing, they respond to evidence that meet their criteria, which is basically something that shows, patient outcomes are improved, there's a lower total cost of care. So we at MA360I, we've created a market research report that looks at the evidence that payers are looking at and the studies that have been done so far for MRD, and whether those studies are sufficient evidence for payers to start covering it, right? And I know this graphic is a little small. What it shows is professional organizations don't yet recommend MRD testing for solid tumors for routine use because they feel like the evidence is still insufficient. Commercial payers, like I said, don't cover MRD testing yet. They consider it to be investigational and encourage use of it mostly in clinical trials. But one part of good news is Medicare does cover minimal residual disease testing for certain solid tumors under specific conditions. So then expanding on that, so Medicare does cover minimal residual disease testing on a cancer by cancer basis. Commercial payers remain cautious, so widespread coverage won't occur until stronger clinical utility data is available and guidelines like NCCN start incorporating minimal residual disease testing into their guidelines. Until then, commercial payers are unlikely to start covering it. So many of you must be enrolling for health insurance right now. So just a quick question, how many of you are Medicare Advantage versus traditional Medicare? So when Medicare, like CMS, says they'll cover minimal residual disease testing for solid tumors, it's mostly just traditional Medicare. There's something called Medicare Advantage, which functions more like commercial insurance. So there's a high likelihood that Medicare Advantage may not cover minimal residual disease testing for solid tumors. Any questions?
We are good so far, Aruna. Is this your last slide? Oh, there
No,
are
I have
questions.
a couple more just, talking about some self-pay options. So some companies like Natera.
Aruna, 1 second. I think that we do have a question from Jeff
Okay.
and Allen.
Okay.
Jeff.
To go on, I have a question that's somewhat related, but not completely related. There's been a lot of confusion also with people that are doing these multi-cancer early detection tests that are not, they have high false positives and false negatives and some huge issues with them. So I know you know the distinction, but I think it might be important to make that distinction because a lot of companies are now promoting these sort of blood tests in patients, particularly in populations I work overseas in about 59 different countries. So, they have incidences where there's very high false positives and patients aren't able to prove that it's negative. They can't afford an MRI. So I think we need to sort of explain that what you're describing is mainly for patients who've already had some incidence of cancer and it enhances their outcomes and, improving switching therapies more quickly than otherwise. But the multi-cancer early detections seems to be muddying the workplace a little bit there. So maybe I may be off base. So I'm interested to get your thoughts, Aruna.
Sure. Yeah, I mean, it's a good point, right? So there are many companies promoting multi-cancer early detection tests. The very companies that are making this minimal residual disease test also have multi-cancer early detection tests. So those are more meant to be like this blood test that you would do on a regular basis, like a screening test where a lot of women do mammogram screening. And then there's also colonoscopy for colorectal cancer screening. So it's meant to be done in tandem with some of that or replace some of that testing where you're actually screening for cancer. So those tests are, basically promoting that you do a simple blood test, then you would understand the risk for, getting several different types of cancers from like 50 different types of cancers. And there are lots of problems with regards to, accuracy. The accuracy is really low for detecting early stage cancer, much higher, obviously, for later stage cancer, as you would see more tumor cells being shed into the DNA, into the bloodstream. But the accuracy is not fantastic for breast cancer and colorectal cancer, et cetera, to detect them in the early stages. So the evidence is not fantastic, accuracy is not fantastic, and it's still a work in progress where different technologies are being put together to see if the accuracy can be improved. Whereas MRD testing that we are talking about here is after being diagnosed, and specifically for like early stage patients who undergo surgery, and then after surgery and treatment, like adjuvant therapy or neoadjuvant therapy, MRD testing would be used to then understand if the chance of recurrence, or if the cancer is recurring, and how to then treat it further if there's a chance of recurring. Does that make sense?
Thank you, Aruna. I see that Alan has a question. Alan, would you like to ask your question?
Yeah, can you hear me? I always hit the mute button wrong.
Yes.
Thank you for the very clear presentation, and I want to compliment you further by trying to give the nuance of that this is emerging and where it is. Because in a patient advocacy group, the tendency, I believe, is for the marketing to get in front of the science. And the net result is people run with this stuff as if it's true or scientifically proven when it's still a work in progress. Thank you for putting the context that MRD is actually slightly emerging earlier than MCED is. And now to my question. You listed Signatera, which I'm aware of, and Brad is aware of, and many people are aware of, and we are a patient advocacy group, so many of us have jumped onto this, but I wanted to caution that it's emerging, and now, actually, I have two-part question. One part is the business end. I can tell you, but I want to know how your hand is on the pulse. My hand is on the pulse as a community pathologist, and I can tell you, Natera has been marketing to us for about 2 years now. Guardant just started to market to us about 6 months ago. Those are the only two players. Another tangent. Thank you for separating tumor-informed from tumor-agnostic. That will be a third question, but I'll save that for other people to intervene. And if there's time at the end, I'll ask about tumor-informed versus tumor-agnostic.
So we have some background. Thank you, Brad. Please go ahead, Alan.
Okay, I'm sorry. So I'm trying to get to my question. I'm sorry. Thank you for your patience. So I'm letting you know I have a hand on the pulse in a backwater area, and Natera is marketing. Guardant has just marketed. They have the division of one. The first is tumor informed, and the other is tumor agnostic. We had a talk from Quest, the billion-dollar company, along with LabCorp and diagnostics, and it was clear to me that they aren't even in the marketing stage. Yet they were giving a talk. It's nice to be informed, don't get me wrong, but one of the problems, the metaphor I use for marketing gets in front of science, is the cart before the horse. The cart before the horse happens all the time. So I'm sorry, I'm trying to get to my business question. Aside from Natera and Guardant, and one more tangent, Quest actually gave us a talk. They are not marketing yet. And there was a consortium, Brad can remind me of the name, but there was a talk from somebody.
Right?
Blood pack.
Blood pack.
Blood pack. Okay.
And I think that's brilliant that there's some organization out there that's trying to collectively make it easier for the all the companies that are startups that are trying to do this to move forward. So here's my question, and I've already kind of asked it. Aside from Natera and Guardant, who do you think is going to be the next 3, 4, 5 players in this field? And then I do want to make one slight editorial. None of these methodologies can be cross-compared except in clinical translational research, which for the ultimate thing, overall survival, is not ready for prime time yet.
Great point. Thank you so much for asking this question. So the Natera as a company is doing fantastic when it comes to MRD, and Signatera has made a lot of money for them.
Yeah, the stock market price is through the roof. Not that I
Yes,
want to go into the business end of it.
exactly, right? So other companies see this and they see that this is a potential gold mine, right? And Medicare is already covering MRD testing for some of these solid tumors. So other companies that have come on board are Exact Sciences, which was recently acquired by Abbott. So they've kind of joined the bandwagon and have Medicare coverage for breast cancer. Bigger players like Myriad Genetics, they're working on a test for renal cancer, MRD testing for renal cancer. There are plenty of others. You know, LabCorp is also developing one. Quest Haystack, I believe, they're not commercial yet, but they've developed coding for their test and believe they can. They also have CMS coverage. So, you know, I looked into the CMS policy that lists out some of these players. There are others besides Garden Health and Natera. There's a whole host of players basically looking at this market because it's huge. And there are going to be at least 8 to 10 other players coming into this market. And Exact launched this summer, I believe, and they also have a minimal residual disease. They are one of the biggest players. After that, it would probably be Myriad Genetics, followed by others like there are smaller players like Saga Diagnostics that's looking into breast cancer, minimal residual disease for breast cancer, and then several others like Tempus and Neogenomics. Yeah, I'm just listing some of them that I can think off the top of my head, but there are several of them looking into this market because this is a huge market. And evidence is coming along. There's been recent success in muscle invasive bladder cancer. I'll show that in a second, where they feel like the liquid biopsy MRD-based test from Signatera actually did show that early enough that immunotherapy can be used and outcomes did improve. So there's a higher chance that muscle invasive bladder cancer, MRD testing for muscle invasive bladder cancer can become part of guidelines. But it's still early days, but there's been some good news on that side at that end of things. Does that answer your question?
Absolutely in totality, except when do you think the next, right now, I'm going to ask a self-serving question. I'm out in the boondocks. Garden and Natera have marketed us. Who do you think is going to be the next person to market us for a particular use, and what will that, who will that be? Because all those players you listed, at least in my mind, are still future. From the patient's point of view, it's here right now because they believe in the cart before the horse. Me, I'm a practicing physician. When will it be marketed and thus marketing is required, believe it or not, because everything's fast moving, and there's no way that somebody's going to start adopting something unless they see the scientific presentation of what its benefit is before they actually even start using it, let alone the medical reimbursement part, which you talked about, and I thank you for that. Who do you think the next person is that's going to market? If I'm asking you to be a soothsayer. Who's going to be the next one to market to me?
Probably Exact Sciences, and
Okay.
they have a lot of money from Cologuard, and they're focusing on this market as something that they want to attack next. And
are they tumor informed or tumor agnostic? Just out of curiosity.
tumor informed test.
And tumor informed. Okay. Thank you. May I ask another question?
Yes, please.
Okay, here's another question. It turns out, you don't know this, but this cancer patient lab is largely populated of all the cancer patients with prostate cancer. You rightly pointed out that MRD the promise of MRD is to pick up things before conventional imaging. Well, that's not operational in prostate cancer because prostate cancer has this brilliant molecule that
And
the that many people poo-poo is inexact, but it's actually the most exact biomarker in all of minimal residual disease, and that's called
yes.
PSA, and everybody knows PSA. So PSA needs. Let me just present it. Kind of like it's a minimal residual disease test itself. It
Yep.
has significant lead time advantage over imaging, significant lead time. My question to you is twofold. One is, well, first off, is to make a statement, and you agree or disagree. The hurdle for MRD in the context of prostate cancer is going to be way higher because they're not competing against MRD is not going to be, or I shouldn't say MRD, I should call it ctDNA. CT and DNA is going to be competing between DNA molecules are going to be competing against the molecule PSA. I imagine ctDNA theoretically is going to win, but it has a much higher hurdle. So is my commentary correct about PSA being probably not the lowest hanging fruit, one of the highest hanging fruits?
Correct. Yeah. PSA is used universally, and it's been around for 50 plus years, and it's very well known, and it's a great test to monitor recurrence. You're absolutely right that the burden is going to be higher.
Yeah.
There are also digital pathology tests that are available that look into like markers post-surgery to predict recurrence. So there are plenty of other modalities available to predict recurrence in prostate cancer that ctDNA will have to then prove to be better. And ctDNA testing or liquid biopsy testing, minimal residual disease for prostate cancer is well behind other
Yes.
solid tumors. Right now, it's ahead in terms of generating scientific evidence and for colorectal cancer, for non-small cell lung cancer, breast cancer, and muscle invasive bladder cancer, and other forms of renal cancer. But prostate cancer
Yeah.
is much behind
Okay.
these other cancers.
May I ask one more question?
Sure.
Yes, go ahead.
I think I'm not sure whether Aruna actually has completed her presentation. Should we first let her complete the presentation and then go open the discussion? I'm sorry for jumping in here.
No problem. Thanks, Doctor. Yeah, I'm happy to take questions as soon as I'm done. So I just have a few more slides. It's not too many. It's meant to be more of like just a guidance education for patients. So, my next slide is just about, just thinking about cash pay. So these minimal residual disease testing, if you believe in it, especially for some of these solid tumors that I talked about, which is basically breast cancer, colorectal cancer, non-small cell lung cancer, and muscle invasive bladder cancer, where the research has shown that MRD testing is ahead and has shown value, but it's not there yet in terms of getting coverage from insurance companies, with the exception of Medicare. You can think about self-pay. There's a wide range of prices out there from anywhere from $500 to $4,000 per test. And this test is a test that's done serially several times during the care. And Natera has financial assistance programs available, and that's the only one that I could find. These other players like Guardant and several upcoming players like Exact Sciences don't have this advertised yet. Natera, being the first company to the market with their Signatera product offering, was the very first one to have this. I just developed a few cartoons, right, to kind of like get patients to think about this. With regards to colorectal cancer, you basically, you can MRD evidence is quite strong here, right? And for like stage 2, stage 3 colorectal cancer, to help enable adjuvant therapy decision making and recurrence monitoring, and it's now covered by Medicare. Like I said, traditional Medicare. Medicare Advantage is not clear yet. It's probably likely not covered by Medicare Advantage. And And then this is about muscle invasive bladder cancer, right? So you can ask your doctor about it. And muscle invasive bladder cancer, MRD test can help identify high risk patients after surgery who need more aggressive adjuvant immunotherapy and more intense surveillance. This is for breast cancer, early stage breast cancer. MRD testing is emerging as a tool to assess if there's any residual risk after treatment. And Medicare coverage there is Medicare coverage, and then there are a lot of clinical trials going on that's likely to shape best practices. We can, again, I'm happy to share these slides and you can look at it in more detail. This is about non-small cell lung cancer. It's for early stage non-small cell lung cancer where MRD is being used to, again, detect molecular recurrence after surgery or chemoradiation. And it kind of helps to then guide immunotherapy adjuvant decisions. And that's been being investigated in trials. So just, quick summary. If the MRD test is negative, it means that there's no detectable cancer, no detectable molecular cancer left after treatment. So it kind of supports having a less intensive follow-up and avoiding additional toxic, chemo or radiation or immunotherapy. So it supports de-escalation strategy and reducing toxicity and improving outcomes that way and reducing unnecessary side effects and anxiety. If it's positive, it implies that there is molecular evidence of residual cancers, even if the scans look normal. And basically prompts patients to the providers, care providers, and oncologists to then closely do more surveillance and actually make decisions on earlier treatment intervention, like starting chemotherapy earlier or adjusting immunotherapy depending on the cancer type. So I just have a table here to just kind of just give you a high-level overview of some of the clinical trials that are going on to establish this evidence that may lead to better data and evidence for further coverage in the future. That's it. I have other slides that I have in the backup that kind of goes through what is the colorectal cancer treatment, how is MRD test used. Happy to share all this, after the webinar.
Thank you very much, Aruna. This is extremely helpful, and for sure, we would love to have your slides if you don't mind. I think that everybody is asking for that. So we have some more questions. Chris, would you like to ask your question directly?
Sure. So I have two questions actually. I was typing the second one. The first one is from a biological perspective, it makes to me much more sense to have a tumor-informed MRD test rather than a non-informed. And I would assume this is, at least in terms of sensitivity, that it should be at least an order of magnitude more sensitive to, and otherwise you actually wouldn't do it. So my question is, are you aware of any data that shows how much more sensitive it is? I'm assuming there are no head-to-head comparisons. Certainly the ones that are coming up with the non-informed are primarily looking at pricing and profit margin rather than sensitivity. What's your gut feeling? Do you have any opinions? Is this an order of magnitude more sensitive or even more, or do you think it makes a big difference? Because if I were a patient, I don't want to take any risk. I want to know, is there anything, yes or no, that's detectable? And I think I would want to have the most sensitive test,
right?
Rather than a test that is kind of good enough and covered by insurance.
Yeah, a great question, right? It's hard to say. As you rightly pointed out, there's no head-to-head comparison that shows, at least between Natera and Guardant's, the Guardant Reveal assay. So it's hard to make a comment on that. On which approach is likely to win out. Certainly, it seems like having a customized approach where where you're looking at the patient's tumor and then customizing the assay after you're looking at the tumor and the profile seems to make more sense and likely to be more sensitive, but Guardant does have data available for colorectal cancer where they are covered by Medicare. And I think their play is more towards monitoring for later stage patients, stage 3, stage 4 patients after they undergo treatment, rather than earlier stage 2, stage 3 patients for adjuvant therapy. Maybe Natera already has the market there, and Guardant's play might be more for later stage patients for monitoring.
So the tumor informed may be good for the decision on, do I want adjuvant therapy after stage 2, stage 3 resection? Is there anything that I really want to undergo? Or do I want actually to skip it and wait whether there is anything we can see? And it's similar to Genomics Health Oncotype DX. If the recurrence risk is low, then I really don't need to have the chemo. And that could be then the Signatera space, whereas the Guardant space could be, I already have stage 4, and I have these type of metastases, and I'm getting now a therapy, and I actually want to see is it working or not, rather than going into the MRD. So these are different indications in a way, and therefore different sensitivity profiles would be acceptable, and therefore it would make sense to have the simpler non-tumor informed one for the question, whereas it's actually not MRD, it's actually residual disease. It's just RD, not minimal residual disease. Okay, so that makes sense. I have a second follow-on question, and that was, you mentioned that the costs are between $500 to $4,000 per test. The value of these tests are not a one-time blood draw. The value are the monitoring. Do you know how this is done in terms of payments? Because the tumor informed have a high upfront costs, I mean operationally, and so I would assume that there is a prime bulk payment, and then there are smaller payments for each of the additional blood draw, or how is it done? Do you know?
As far as I know, each payment is the same, right? Because even when it's done serially, like the first test, and then the second test would be done like, every 3 months, just like a regular surveillance, imaging surveillance. And every one of those tests are paid the same amount. I don't believe the cost is different for the surveillance test. I might be wrong. As far as I know, that's what I've seen in terms of payment from insurance companies. Like each surveillance test gets paid the same amount.
Yeah, I don't know if this answers the question, but the initial setup obviously involves a second test. So a pathologist would send a tumor block, and that's how they would get the signature. So that would be the additional test up front, whereas the subsequent liquid biopsies, I believe, are all the same price.
Correct.
How much is the setup? How much are the biopsies? Do you know, roughly?
The tumor block being sent to do like a
no, I'm not asking how much it costs to send the tumor block, because unfortunately pathologists don't get paid for that when they get this request, and which is a cost for them that they don't get reimbursed for. And the question is, how much does the company charge for processing to do the tumor informed profiling? And then how much would then be the individual costs? Because the tumor-informed profiling is probably the bulk of the cost, or should be the biggest one.
Correct. You're right. I mean, but as far as I can tell from reimbursement amounts, it's all the same reimbursement amount. So Natera basically has a collaboration with Foundation Medicine where the block is sent to Foundation Medicine for profiling, and then they pay Foundation Medicine based on whatever amount Natera ends up getting. And then that informs Natera's assay, which they then perform serially. But the serial assays are reimbursed the same amount as the very first assay as well.
Okay. All right. Thank you.
Thank you. I see Alexander has a question as well. Alex, are you still here?
Yeah,
I'm here. I listen once I hear the
I
voice.
can read my question. Looking at the current state of the MRD testing, what is the correlation between false positive and false negative results?
I mean, they have a very high sensitivity rate, close to 95% plus, sometimes even 99%. So the false positive rates are really low. And that again varies, from a cancer to cancer. For colorectal cancer and muscle invasive bladder cancer and breast cancer, they've shown really high really high sensitivity and specificity, so low false positives and low false negatives. Whereas when it comes to something like non-small cell lung cancer and other cancer types, it has pretty much lower sensitivity. So the false positives and the false negatives are higher, So like sensitivity for lung cancer is anywhere like from like 70 to 80%, and it needs to vastly improve. Whereas it's in like the 90% plus, like 95% plus for other cancers like colorectal and muscle invasive bladder cancer.
What about the prostate cancer?
Oh, prostate cancer, it's not even there yet. They're still developing it. So the sensitivity and specificity data hasn't been published yet.
Thank you.
Sandra, you're on mute.
Thank you. Any other question from the audience?
I believe Rick Davis.
Can you speak to the value of MRDs for pancreatic cancer?
Again, like, pancreatic cancer, most of the times that it's detected, it's quite late stage. And I'm not entirely sure about the percentage of pancreatic cancer that can be resected. So the value of MRD would be for those that can be resected to then do the MRD test to figure out if there's any residual disease and if any sort of adjuvant therapy can be given for those that are at high risk to then prevent recurrence. Majority of pancreatic cancer ends up recurring post-resection, and it's a deadly disease, and majority of it is detected at late stages. So the value would be for those few cases where it can be resected.
Thank you. Rick,
The
I think
audio is
you
off
have a
on.
question.
Yeah, I was asking about the tumor-informed MRD for pancreatic cancer post in a adjuvant setting.
Mm-hmm. For pancreatic cancer?
Yes.
Right. So it would be used to guide, chemotherapy decisions, whether to combine multiple chemotherapy agents, or a single chemotherapy agent would suffice for the adjuvant setting. So the tumor-informed approach would basically be, post-resection, it would be sent out for genomic profiling, and that would then inform the signature that they'll follow, right, for surveillance, for liquid biopsy-based approach. And that would basically then help doctors then inform, okay, how many chemotherapy agents should I be combining for adjuvant therapy setting?
Thank you. Rick?
Yeah, I want to come back to this prostate cancer issue. I, based on having navigated many people post initial treatment and I'm well into advanced prostate cancer, I would strongly disagree with both Aruna and Dr. Morris that PSA is effective. In fact, many GU medical oncologists disregard PSA, and there are a lot of reasons why. I don't want to get in. I'm happy to discuss it, but I don't think this is the right forum. We are really looking forward to some type of MRD test because it's sorely needed at many stages, immediately after treatment, and especially further down the road to determine what treatments to continue with. I don't understand, with such an enormous market in metastatic prostate cancer, why prostate cancer has lagged so far behind. Can somebody, Aruna or anybody else, explain to me why we're all sitting in the back seat here behind colorectal and breast and lung when the product's so needed?
Hey, Rick, can you you have a greater hand on the pulse of the general prostate community that you serve? What % of patients do you believe never have a rising PSA when they are at the end? Are there a lot of patients that don't have rising PSA?
I don't want to get into that here. The question here is why are we so far behind? Be happy to discuss that with you offline later if we have time.
You can't
But
tell
why?
me. You have to know. You
No,
have to
Alan.
know.
Alan, this isn't the Alan show.
Okay.
Okay? This is not the Alan show. I am asking Aruna a question.
Okay.
You didn't give her a chance to answer.
Okay.
The moderators have been really easy on you right the way through. This isn't right.
Like, I'm not the science expert, right? But I can give you from a high level understanding of from what I know. Prostate cancer's biology is a bit different from others like colorectal cancer, and has been the biology has been a little bit more difficult when it comes to looking for circulating tumor DNA for MRD. That's not to say it's not coming. It is coming, but it's lagging behind colorectal cancer and other cancers because of the biology being a little different, especially for prostate cancers that are resistant, like castration-resistant prostate cancer. The biology is way more harder, and it's just lagging behind others. Specifically, I think because of the biology, but I'm not a scientific expert by any means.
Yeah, I would like to add that I agree, Aruna. I think that it has to do with the amount of circulant tumor DNA that comes directly from the tumor. That's one of the limitations in order to implement minimal residual disease based on ctDNA for different cancer types. However, well, there are more methods right now that are leveraging the whole genome sequencing, which increases significantly also the power and sensitivity. So, yeah, for sure.
And also the sample type, right? Maybe blood is not
Yeah.
the right sample. Maybe urine is the better sample.
So, I would dispute that because we don't see a huge number of genomic tests, liquid biopsy genomic testing getting rejected. Some, but not a whole lot. And we can probably get a liquid test result at fairly low PSA. So it suggests to me it is shedding okay. I would think it's more related to the fact that prostate cancer, and I don't know enough about the other cancers, has a likelihood to morph. So the disease is changing very quickly, and not very quickly, but the disease is changing and changing more constantly, and that might make it more difficult to identify exactly what is out there in the bloodstream. But it's just a puzzle to me. I met in February. I talked to the Natera people at GU ASCO, and they were really nice. And they said, look, if you've got any guys, you can send us stuff. We can try and run whatever we can. Of course, it wouldn't be tumor informed, but it's just, I don't know. I was hoping I'd get an answer, but
Rick,
I will keep trying.
Have you heard of Artera?
Sure, but Artera is a different. Artera has a completely different use. Artera's use is early in the disease to determine whether somebody should add hormone therapy to radiation. That's the purpose of Otera. I would say, not completely different, but really another ball game.
I'm adding that topic for future presentations, Rick. I'm sure I recall that I have seen some data with prostate cancer and minimal residual disease based on whole genome sequencing. I will look into my notes. I think that there was something presented in ESMO this year, but I will follow up on that.
Thank you, Sam.
Of course. We have a couple of minutes, and I see that we have more questions. I see Darren.
Hi.
Hi, Darren.
I work on something somewhat related in brain tumors. This is the question of has recurrence happened or not, and it tends to be a bit clouded or obfuscated by the issue of radiation necrosis. Oftentimes, patients have had stereotactic radiation, and it causes a lot of radiation necrosis. It makes it difficult to determine if the MRI is suggesting that there's a recurrence or whether it's just radiation necrosis. And so I was interested in using these kinds of tests to determine whether or not the, say, glioblastoma is back or not.
Yeah, glioblastoma, I haven't seen MRD being researched for glioblastoma, but again, I haven't had a chance to look at all the new abstraction posters from ESMO or the San Antonio Breast Cancer Symposium. So that would be something I'm not.
What about
I wouldn't be
personalis? Personalis versus Natera?
Yeah, so personalis also employs a tumor-informed approach, just like Natera. But their approach is slightly different, where they also do whole exome sequencing. So the Natera is also expanding. So again, so the Signatera assay, you send the block over to Foundation Medicine to do a genomic profiling. So what sort of genomic profiling do you do is the question, right? So the Foundation Medicine assay that they do right now is a panel of about 350 genes. So you could do whole genome sequencing or whole exome sequencing on that tumor block, and that would give you a broader sense of what sort of mutations to follow for your MRD-based liquid biopsy assay. So there's a difference in approach there, and both Signatera and Personalis are looking into those different approaches and what makes sense for which cancer. So that's the only difference. Personalis is also attacking different cancer types. So Natera is focused a lot on colorectal cancer and muscle invasive bladder cancer. Personalis is actually looking into breast cancer, and they also have another assay that looks into uropharyngeal cancer, head and neck cancers for people who tested positive for HPV. And are high risk for that. So those are some of the things that Personalis is looking into.
Would the blood-brain barrier be a factor in being able to read circulating tumor DNA?
Not that I'm aware of.
Well, thank you very much. We are 1 minute over. Thank you for the great presentation, Aruna, and everyone also for the engagement. Aruna, I was wondering, I don't know if in the other slides that you didn't show, if you may have like a slide where that shows like all the companies that are participating in MRD or some of the most relevant companies that you just mentioned. I think that that will be very helpful for the participants. And also, I don't know if you could add also like what types of cancer types they are currently serving. I think that that would be amazing if possible.
Sure thing. Yeah, I don't have it right now in my slide deck, but happy to add it. I have it in my back pocket in one of my Excel data sheets. So happy to add that slide.
Thank you very much. I'm sure that that's going to be very much appreciated by all our cancer community. Thank you very much. And with that, I think that we can wrap up. What would be your closing remark for today's presentation, Aruna? What would you like to all of our patients to have on as summary of this meeting?
So, again, thank you so much for giving me the chance to talk about minimal residual disease. It's for solid tumors. It's an important advancement, something to be aware of. Hopefully, there's more evidence generated and more insurance companies start covering minimal residual disease testing, as it's addressing a very important need of detecting cancer early.
Awesome. Thank you.